So welcome everyone. I'm Alison Beck. I'm a postdoctoral research fellow at the University of Wollongong and affiliated with the NHMRC CRE. And we're very pleased today to have Holly Stokes with us presenting on research translation. Before we do go into the presentation, I'd like to start with an acknowledgement of country with a beautiful video that University of Wollongong has put together for us. And hopefully everyone will be able to hear and see.
We acknowledge that country for Aboriginal peoples is an interconnected set of ancient and sophisticated relationships.
The University of Wollongong spreads across many interrelated Aboriginal countries that are bound by their sacred landscape, an intimate relationship with that landscape since creation.
From Sydney to the Southern Highlands to the South Coast. Fresh water, to bitter water, to salt. From city to urban to rural.
The University of Wollongong acknowledges the custodianship of the Aboriginal peoples of this place and space that has kept alive the relationships between all living things.
The university acknowledges the devastating impact of colonisation on our campus's footprint.
And commit ourselves to truth-telling, healing and education.
Psychology.
Okay. So thank you everyone for coming along today. Holly, I think I've stopped screen sharing now if you wanted to pop your one up whenever you're ready. So the purpose of our group is to be able to provide some mentoring and support. We really want to be making the most of everyone's professional development throughout, in particular, early career. And so we're very excited today for Holly to come along and present on incredibly important topic when it comes to research is around translation. So Holly is the Research and Outcomes Coordinator at Lives Lived Well, and she brings with a wealth of experience. So looking forward to hearing more from her today. So over to you, Holly, whenever you're ready.
Thanks very much, Alison. And that was a really lovely introduction. I've not seen a welcome to country done like that before. That was really, really nice. Ooh. So to kick us off, we've also got our acknowledgement of country, but I'll keep ours brief as we had that beautiful one to begin with. I'm speaking to you here today from Yagara and Turrumbul country, and I'd like to pay my respects to them, the elders past, present and emerging. And I'm going to be showing a few different sort of research projects I worked on, and they were conducted across Australia in Kroona, Yagara, Yugambeh, Giabel and Jaraware lands, which is Adelaide, Logan and Toowoomba. Okay, so I thought this was a really nice way to sort of start looking at the concept of translational research. So when I was really considering this as a topic to speak about, I thought, well, you know, the name translation, I think it really defines everything about working in translational research, either as, you know, an organisation or an academic body coming into the experience. And I thought, you know, even from all my experience, so much comes down to just that shared language. So I've put on screen a couple of, I think this is one of the biggest hurdle to get right over, right at the beginning of connecting with organisations, researchers and clients and clinicians, is just to get a sense of the terminology that we use and the meaning behind that. And I think when people can get language and understanding sort of really cemented in their mind, you can really start the project, I think, in a much more kind of positive space and a much more shared space. So you can see, probably for those of you who have been in academia a long time, there's some really, I guess, obvious terms and words that get thrown around to a point that we don't even think twice about it anymore. You can see, yeah, just the familiarity of that. Maybe some of them make you cringe because they're very embedded in statistics, which can be hard sometimes. And others maybe one that you celebrate, such as things like effect size, which is exciting. And then there's the service provider. So I've come at this from a lives of well perspective, but to be honest, every service I've worked for, and I've only ever worked for not-for-profit organisations in healthcare and AOD, they've all got their own sort of terminology they use. And that can be equally as, I guess, difficult to unpack and understand and to be able to communicate with. So these are common words that we definitely use here at Lives Live Well. And often it's language that's built within our service, language that's built within our discipline. So whether that's social work or counselling or psychology, it's also language that's been built by a lot of our funders. So I think that that's something to really understand as well, as to how much we have to adhere to the terminology that our funders set for us. So the really obvious one is the one right at the top: cease to participate at expiation. What on earth does that mean? I mean, this is one even working in the sector. And when I worked for CUNATA, this was something that constantly came up, that particular term. It took a long time to even get what that was about and how that related to our clients and to our programs. And then, of course, we've got the client voice in, and I didn't want to leave that out, and you'll see that peppered throughout the presentation today, is I think that this is a really positive area that we're moving towards, and that is the role of the client, their voice, their understanding, their interpretation in research projects. I've experienced this very much in my work, particularly around doing reporting, where it was actually the client's interpretation that totally nailed what I couldn't see in the research data. So, of course, they come to the party with their own sort of language and use of words. And some of these might look really familiar, and you might then have a bit of a guess and say, oh, well, you know, I know what admissions means. Well, from the perspective of a client, that can be actually quite different. It may not be that kind of quantitative measure of point-to-point experience. For them, it might be wrapped up more in, I guess, the emotional side of things, or that point when they leave community to arrive at a particular setting, to the point where they feel that they're comfortable within their new treatment environment. I also do some of these terms used by the client. I'd actually have taken the liberty of borrowing from a publication my friend Craig has recently done as part of his role into looking at the client voice in various treatment services around our organisation. And I literally went through, and he's done verbatim how clients express their particular their experience with the service, and I pulled words straight out of there. And one that was, I didn't include it, but it certainly grabbed me, was a client had used the term spaced out. And I think it really highlighted my own bias, because I knew these were clients in AOD treatment, and I saw the term spaced out, and where did my brain immediately go? Was, oh, this is something to do with intoxication, use of substances. But when I read further into the document, the client was actually using that term in relation to how programs are shifted, and programs and sort of activities are shifted and spaced out during a day over, you know, the 6-week setting that they're there for. And I think that really, I mean, that was a bit of an eye-opener and awakening for me as someone who's worked in AOD for 14 years. I think that was a good example of how my own biases can really trip things over, particularly when it's looking at, you know, if that was a variable to measure or a particular, you know, research outcome I was looking at. Also, as well, for those who do work very much in academia, I really encourage you to do this particular exercise. It is damn hard, and kudos if you can manage it, is to look at some of those terms on the left category and give it a red hot go to explain what they are to somebody that doesn't work in science or anything of these types of professions. And I did have a crack at this recently, and I think I failed miserably, but it was also a bit of an eye-opener. And this was a colleague of mine. He's incredibly intelligent. He doesn't work in science or clinical work. He's in IT. And we were trying to explain to him why a research project I'm currently involved in, it's a randomized controlled trial. Why is it that we're randomizing going to these different regions? Surely that's a very expensive thing to do. If we just know what order the regions go in, we can save a lot of money as an organization. 100% he's correct. And so there was my opening to explain what randomization means and why randomization is such an important empirical thing to, scientific rigor. And I said, this is going to absolutely prove that, what we're doing is just purely, based on our activity and nothing else is interrupting it. And he said, what do you mean interrupting it? What else is out there? And I said, well, if we, we could choose to go to orange like in winter, but maybe the snow would make people cold and then that would be a confounding variable. And I just realized I was digging myself deeper and deeper into this ability to describe, what randomization is. But I think that was a really good lesson for me. And I think when it comes to translational research, if you can't describe those, basic scientific topics, you're going to sort of have a hard slog at the beginning. Yeah, we'll have a look next. So what are we going to focus on today? There's kind of the way I was sort of looking at it in terms of my experience and sort of what's out there would be most applicable to this group. And just to preface, I'm not an expert in translational research. I actually come of it more from a professional background. So I've been involved in projects for a really long period of time, since I think about 2007, 2006. And have seen the absolute immense value behind them, seeing what's gone very right and what's gone very wrong. So at first, we're going to have a look at practice. And I've got 3 different examples of research programs I was involved in. And we're going to have a look at this thing called the Valley of Death. It sounds like doom, and damn, it is doom. When I really started to read into this, I thought this is the best explanation I've ever seen of what it's like to work in translational research. So we're going to have a look at how that kind of plays out in a practical sense. Then we're going to have a really quick shoot over to policy, because I think that's kind of the forgotten cousin of translational research. I think we think of translational research as these massive programs and projects that get undertaken. They're really expensive, involve many people, but sometimes it's just, that influence on policy that can just really help to leverage the strength of an organization in such a simple way, but an incredibly effective way. And then finally, publications. And I've highlighted that word discussion. For those who have done any form of research knows the values of abstracts and discussions. And that's something that we'll have a look particularly at today, because I think it is, again, another area that really can lend itself to practice. So having a look at the concept of research translation. To be honest, I had never really thought of it from a very kind of theoretical perspective. It's just, to me, it was something that was done. It was practical. It was, driven by evidence, and it had a great outcome. And that's probably as much as I ever gave thought to it. But there's kind of 2 versions or 2 ways of thinking about research translation. And I actually like both of them. And I can absolutely see validity in both particular models. And I can see, to a degree, these 2 coming together a bit more in the future. So we've got what's called the research pipeline. You can see that just down the bottom. That's basically the linear process of research. And it's probably very familiar to people who work in immunology or any kind of our pathology research. It's where it kind of looks at that real basic micro level of research and investigation, runs those human trials, and then pushes it out to the community, and eventually it's standard practice. I think, looking at the development of the COVID vaccine, it most absolutely runs through that trajectory of that real typical bench to bedside rollout. So the other side of it is now this evidence-based practice, or EBP, which really practice that a lot at Lives of Well. And I think it's sort of really lends itself very much to the social sciences and health sciences. So it combines the thoughts of expertise and evidence, clinical skill and knowledge, and patient need and preference, which I really like. And as I was saying before, it'll be so great to sort of start having that client good moved into this research setting. And I think that this kind of evidence-based policy Venn diagram does a really good job at doing that as well. And of course, both comes with their positives and negatives. So I think, potentially like looking at that research pipeline, there's often fears that, in a space like a clinical space, like somewhere like Lives Live Well or similar organization, that it's lacking in that informal, implicit knowledge, that it's derived, predominantly through practice, which sort of makes it less reliable. Whereas, if we look at the evidence-based practice, it's sort of, I guess it's bringing a new sense of transferability. And that is something that the research pipeline has always feared, is that through a lack of that kind of scientific rigor, we're going to lose that ability to replicate and transfer our findings. But I think I've got a few experiences that is really going to challenge that notion that transferability can occur within that evidence-based practice. So here, as promised, is the valley of death. So this particular, and I really encourage anyone to read this particular study because I found it fascinating. It is more along the lines of that research pipeline as opposed to evidence-based practice, but I think it definitely lends itself across both. And basically, the valley of death is described as where promising discoveries meet their demise. So I know that sounds like really morbid and tragic, but I think there's a lot of value in understanding this, that we have ideas and concepts and hypotheses that are bred in this kind of academic environment. We desperately want to sort of push them out into more humanitarian space. Likewise, you've got people who are working and contributing to that humanitarian space that desperately want to pull across some of that academic learnings and knowledge. And in the middle, this is where we have translational research. And this particular author has put together this kind of list that if there's going to be a problem, this is where these problems are likely to occur. So things like what is the clinical relevance? Is that something shared in academia and industry, or is it one or just the other? Things like funding as well. And I think that comes just hugely when we talk about research translation, both from a university perspective, and I know definitely from an organisational perspective too. And things like incentives and the time it takes. Definitely translational research is often criticised for how long it takes to implement and to go through. So he's given us a lovely model to work with, which is sort of how I'll preference some of our different research projects that I've worked on. So this is one I was involved in way back in 2007. With Anglicare SA, and this was not a, I guess, rigorous kind of academic research piece. This was something that was very much built within the organisation. So the setup that we had was, I think we had approximately 60 residents living in this kind of three-tiered nursing home situation, and there was opportunities. It was pretty well staffed, so I was very lucky. I worked as a diversional therapist in this setting. Not a lot of nursing agencies had this role and access to this service, but we were very fortunate that we had a couple, and I think that played a key role in us being successful in this project. We also had a co-located physiotherapy team, which again worked very much to our advantage. So it meant the clients didn't have to go too far to attend to their physiotherapy needs. And we also were very lucky to have a bit of funding to employ a registered physio chi instructor, which I know sounds very interesting, but physio chi is generally built on the idea of Tai Chi, but it's for people that can do that while they're sitting down or in wheelchairs. So it's like a modified version of Tai Chi. And it's got strict instructions that come with it, and you do have to be accredited to be able to run it. So what we did was very much notice that there were the number of slips and falls within the nursing home was sort of concerning. Even one is concerning, but I think we'd had a few, and it was time to sort of address that need and what could help. We noticed that a lot of our clients, they did go to physiotherapy. It was done on site. We had very qualified staff, a team of, I think, 3 physiotherapists at the time, exercise programs, but compliance and attendance rates were really low. I think a lot of the residents just felt that it was quite exhausting to do, that they couldn't see the motivation. There wasn't a real kind of, incentive. So then we also sort of talk, well, okay, we need them to sort of really participate in physiotherapy, but is there a better way of doing this that's more engaging, more enjoyable? And that was when the physio chi came in. So it was something that we would have as a group and participate, and they would actually blend the physiotherapy exercises in with the physio chi performance, which sounds very technical, but it was something that everyone worked together to sort of achieve. As a diversional therapist, my role was very much in determining motivation to attend the group. So trying to get these clients every week to come to the group, perform the little activities, and sort of start to reap those benefits of, stronger bodies and muscles, and hopefully reduce falls. So if we have a look, here's how it fits really nicely into evidence-based practice. So you can see that, starting with the patient values, and this beautiful woman down below, one of the things that really got her to attend is she loved dancing so much. And so we bought feather boas, and all of the residents could have feather boas, and we would play music, and we literally called it a strip tease. And we played really sort of suggestive jazz music. And it was probably so inappropriate. It was a highly religious setting, but that's what got people coming. And it was really fun. And so that became the draw card. And then when they saw others coming as well, it started to become a social event. And then you can see that blending of scientific evidence and patient values. So there's one of the residents in the middle pushing that purple ball. That's actually to help with spine alignment. She didn't know that. She didn't care. It was, a great little activity, and we'd actually start passing it from person to person, and they would bend it forward, and that was helping with their spine. And we'd kick it back and forth and pretend it's a soccer game. And it was all, very, very enjoyable. And then, of course, we had the scientific evidence behind it. So our physiotherapists had put together a particular program, and they were very much focusing on improvement of dorsiflexion and plantarflexion, which is kind of the way that your heel and foot works as you walk along. And as we age, that particular muscle isn't very reliable anymore, and we tend to trip over. So that was something really strong that the physiotherapist said this must be included in this particular protocol. So then to one side, we've got our physio chi. So the idea of sitting down and doing the physio exercises. And that was going to be run by all of us. So every single one of us who are involved in the project were sent off to get our accreditations, including myself. And there's my certificate. And I went for a 2-day training course to better learn how to do these physio chi activities. I was also working part-time in the physiotherapy department as a physio assistant. I have no qualification as a physiotherapist. They were just a bit short-staffed. But from that, I learned about things like dorsiflexion and plantarflexion, and how important it was to be able to pull your toes right back to really exercise that muscle. And then finally, right down the bottom, we've got the clinical experience. So that was me, and there's my colleague there. And that was how we were going to get people to attend the program. And that was using our knowledge of our people-based skills and our experience as diversional therapists. So it was, a fantastic program, and the results were really, quite positive. And for a couple of reasons, I think that this one worked well. It was a small study. It was internally done. All of us were based in the same building, which really helped in terms of communication. All of us were then trained in each other's areas of specialization. So again, that you've got that real consistent inter-rater reliability, because we absolutely understood the value of each of our roles in that position. In terms of data collection, it was super easy. We had, your standardized measures. They weren't hard. You didn't need training in them. Easy to fill out and easy to sort of put through to an Excel sheet. Monthly attendance records, we basically use them to track client attendance at programs. And also, and I think this is worth thinking about with research projects, is most organisations do have to adhere to quite, I think, complex standards to be able to maintain accreditation. So, of course, nursing homes, absolutely. We had very strict reporting standards around falls and very strict kind of outline criteria of what a fall actually is. So in terms of defining your variables, these sort of external organisations really help to produce something consistent by which we could measure ourselves against. So it was, really helpful. And so what did manage to get us through the valley of death? Really, and I think this is probably a terrible comparison to make, but probably the hardest thing that almost didn't get us through the valley of death was actually death itself. So when you're working in an aged care setting, and this was the first time I'd always heard in psychology the term attrition and mortality, and I thought, why do they call it mortality? And then this study, I finally really understood this, that mortality was the passing of your participants. And for many of us, this was actually much, much harder because our entire group knew each other. The physiotherapists who were conducting the research knew these clients. So it did actually take a real toll on our particular study. But I think other than that, what it was really good at is, I think nursing homes are great for proving this can't pronounce that, like the ability to reproduce scientific research. And I say that because aged care homes have really defined inclusion criteria. It's very strict because it's often government funded. The program already had been built from a health science perspective. So we knew from a physio perspective that this was legitimate. And aged care residents have a real preference for routine and predictability, which is absolutely brilliant. Like they would sit in the same chair every single time. So they would literally kick out their own confounding variables by being so incredibly consistent. So it was just, we were very lucky to have that perfect setup. Definitely the collaboration was the biggest winner in this as well. And that, you know, in terms of risk, it was very low risk. We were co-located, cross-disciplinary, a lot of supervision, a lot of training. So it was a real straightforward win, and it did reduce the slips and falls in our service, which is good. Then the second one I worked for was back in 2012. I was working as the national coordinator for SaverMate with the Australian Red Cross. And the SaverMate project, we were very, very fortunate that we had some funding to be able to invite Burnett Institute into our program to give us, I guess, a real overview and evaluation of our service and its effectiveness and its sustainability going into the future. So pretty much the main aims were looking at things like impact, looking at things like relevance and appropriateness to the target audience. Certainly when you're working with young people, this changes very rapidly. To develop reliable indicators for future monitoring and valuation. We really fell down in this area, and they were going to be very intrinsic in helping us to develop an evaluation model and to generate knowledge to inform future funding submissions and social policy positions and advocacy in general. So really great, very well fitting aims with our particular service and project. So it really ran to more of that research pipeline way of kind of progress. This was done over a 1-year period. So you can see it was quite involved. We did have fellows and research assistants, quite a large reference group at Red Cross, quite a large number of facilitators themselves, and of course the young course recipients fed into that process too. So Burnett Institute, it's historically and very well known for its work in that kind of, I guess, micro and macro level of understanding human functioning and human behaviour. They're really good, I think, at the public health side of things. I think we chose very well to go with them. The Red Cross do have their own research department, so I was a little bit involved in that, but they certainly did have a strong research agenda. They are, of course, affiliated with the blood donation, so they really do have a very high expectation of them as a service. And then, of course, the SaverMate program itself, which had, you know, quite a large number of clinicians working for it. And then finally, the actual product that we rolled out. It also, and I think before when we're talking about the research pipeline, that it's, even though it's generally linear, there is opportunity for intersection from other external sources. And this one certainly was. We had a manual and a training kind of agenda that was introduced to Red Cross in 1995, and it was a mother who actually wrote this particular overdose manual after she lost her son to a heroin overdose. So the core of SaverMate was actually built on this HOPE program, and that agenda and sort of early history was certainly not forgotten when we were sort of doing that research. So primarily it was very much evaluation-based qualitative interviews, thematic analyses, which is good. One of the things that Burnett did very well, and we sort of had to match each other a bit with this, that I think was effective and probably quite funny, is we had to get very creative with our data collection. So we would attend music festivals, and we would probably, these music festivals were probably seeing 200,000 participants a year through this particular program. We might only have, say, 12 volunteers to manage 140 overdoses. So it was really full-on environment, and the ability to collect any form of feedback or any understanding of our success was really difficult. So we sort of invented and brought into our processes with thanks to Burnett Institute. Things like having clickers at the front door. So as people came through, we just clicked rather than wrote down or ticked off. It was much easier to sort of keep a record of numbers that way. We actually would, I guess, we would count our inventory and resources almost back to front. So I would know that I put 100 flyers on the table at our little stall. And then at the end of the day, I had 3. So that meant I had distributed 97 flyers, and therefore 97 individuals had benefited from some level of harm reduction support. So it was a very sort of back way of doing things. We even did it our sunscreen as well. We had huge amounts of sunscreen. We'd distribute, everyone got 2 pumps each. We were pretty much able to work out how many people at a festival we had sunscreened based on these quantitative measures. And things like, you can see our little lovely prize table. So when people answered a harm reduction question, they got to take home a prize. We could measure how many people had done that based on the number of prizes left at the end of the evening. You can see, I think some condoms have gone out, so that's a positive. That was a good session. And then Burnett itself, they really had to get around the whole working with the under 18s. So the majority of our young people didn't have family, were either in custodial settings, were in foster care settings, were in group homes. So they really had to exploit that Gillick competency to be able to get, the best feedback, because we wanted the under 18s. They were most integral to this particular project. So that was, something that they pushed quite hard for us to be able to get as well. And also, thinking of the time, this was 2012, that Zoom and Teams was not really a thing back then. So they had to get around a national program and interview a lot of people. And that was certainly really difficult to do. And they had to be very inventive with their inquiry. So what did Burnett support us with? We did get an AppSide presentation. They are absolutely translational leaders. I think what they did really well is that a lot of the relationship building, they just took so much time to get to know us, get to know the organizations, knew exactly what our roles entailed, and the whole history of the program. They knew everything about the program itself. They actually read every single key document, which is massive. It's a huge organization and program with 20 years behind it. And a lot of, I think nationally, we had about 40 to 50 clinicians. There was a lot of flexibility in their methodology. So it was so adaptable when we said, I'm sorry, we can't get you these clients, they've cancelled on us, or we're going to have to drive you 3 hours out west, even though I know you said you came to Brisbane, but that's the only way we can get the people that you need to see. And their humanistic values, I think right off the start, they viewed the staff and participants as experts in their own rights. So we never used formal titles. I don't even know for a long time what academic titles the research team had. They were sort of never used, never referred to. They dressed really casually when they came to see us and sort of really fit within the culture of our service and our program. And then finally, they were very transparent. They always involved us in things like their preliminary findings, got our feedback on what, early data was showing and what they thought we could actually do with these findings, which was great. So did we survive the valley of death? Unfortunately, we did not. So despite having such an excellent experience with Burnett, and this is no fault of theirs, this is then the other side of the valley of death was industry and organisation where it failed. So after 20 years, Save a Mate was shut down. I was actually made redundant in 2015 as part of this process. And I think where the issue kind of lied with it was a couple of things that came in. And that was big one was the clinical relevance. So that's this valley of death was a real killer, and that most certainly was. So Red Cross has really strict values around working with the most vulnerable members of society and community. That is embedded in their entire international framework of Red Cross. So despite all the evidence that Burnett came up with, the organisation and the community that supported the organisation said that young people who use substances at a festival were not seen as vulnerable, because if you can afford a festival ticket, then you're not suffering, you're not vulnerable. We kind of really pushed around that argument that is a the festival is its own community, and therefore they are vulnerable. But this was a really hard one to sort of push, particularly given that this is 2012 we did this study. We all know what happened in 2011. I was working for the Red Cross when the floods occurred, and it just stripped the energy, the effort completely out of that organisation. Its priority totally did a 360. And I really can see their argument here in terms of what vulnerability looks like. Risk was also a big issue. We had an ageing support base, and they often found that harm reduction was a hard pill to swallow, pardon the pun. But they were really worried about a reputational risk, and we had a very conservative backdrop that made this hard. All attempts to kind of push through policy that would support this were very much delayed a lot, which then comes through the follow through, was that it's such a large organisation, and it slowed progress on pretty much anything that we were trying to get traction on. So we really just missed the boat. And that's not Red Cross's fault. That is just the way large organisations operate. And maybe our goals were just way too big for what we could sort of feasibly achieve. And then funding was a big issue. So we did really great at getting funding for Burnett. That was over $100,000 for that study. We started to actually action some of the recommendations, but of course, in terms of its long-term sustainability, it wasn't a fee-for-service program initially. It just couldn't keep floating through the funding tides that were changing very much. So, and then the third one that I'm going to have a look at is our sleep in recovery study that was done. So this one's close to home. This was with the University of Queensland and Lives Live Well. And there's many that we do with University of Queensland that have been hugely successful. A lot of them are very long studies. So I've picked this one in particular because it was had a very definitive start and end point, and it was a much smaller sample size they worked with. So it's kind of got an easier way to sort of track how it was going in terms of its rollout. So if you don't know about the sleep in recovery study, basically the aims of that was to look at practicality, feasibility, and accessibility of measuring sleep activity and the sleep environment of people in recovery from substance use, which I think was incredibly kind of it was really tangible and really applicable very much to the people in our organisation, certainly when they're in that recovery space and early on. I'm just trying to get back into a good sleep pattern again. Good sleep hygiene, good circadian rhythm is a really tricky thing. So they hit the nail on the head straight off when they said, we think that this study might be a good fit. So they also wanted to look further into the different factors, such as environmental and individual, and how they associated with good sleep. So again, this is where they pulled into those clients. They were very involved in the clients, and I think straight into the aims, I think was what really sort of helped that involvement. And finally, to consider sleep-related factors that could be associated with a person's recovery outcomes. So this was very much clinically focused or organisationally focused, because it's looking at what particular factors could we change as an organisation to help improve people's sleep. So it was a really easy kind of, I guess, research to sell. So they had 49 clients that kind of completed the study, recruited out at Logan House, the family residential units as well. And the clients wore actigraphs for 14 days. They kept a sleep diary, completed routine outcome measures, self-report measures, and had interviews. The clients generally reported that their participation in the study was easy and non-invasive. So the basic results from that, they were all really positive and gave us something to work with. They found that sleep-wake regularity was associated with mood, that clients reported less disturbed sleep by exit. So by the time they ended with our service, things were definitely getting better for them. And better sleep quality was associated with improved client satisfaction results. That's definitely a win for us. And overall recovery is an ideal setting to improve healthy sleep. So here we have a captive audience. That's what they're going to be doing probably every day for the next 6 weeks. And here's something that we can really influence as part of their treatment. So did we conquer the valley of death? We absolutely did with this one. And I think in the most kind of practical and I think, yeah, the most practical and kind of simplest perspective is what made this one successful. So pretty much the research team came to us quite early. So even though this was over a year, it was probably started closer in late 2020 that they began to think about this. And I found that their hypotheses were not about, were about testing them as opposed to finding evidence to support them. So they were sort of coming at it in sort of, we've got these ideas, we want to run with it. I don't know, I felt they were very invested in the study because of course there's funding behind it and there's time behind it. But I also felt they were very open to the idea of this just not working. And I think that's what made it a lot less stressful. They weren't pushing for a particular outcome. They were going in very much like, hey, let's just see what happens. Also, the number of variables they needed to collect was actually really minimal. And I think that's what made this one much easier. So we already collect quite a large number of data through outcome measures that we routinely do through our NMDS data collection, which is mandatory for all services like ours. So we had, generally good practice at being able to collect this. We knew that we were capable. We knew that we had the systems to collect it. Okay, it's not going to be 100% all the time, but it was something that was familiar to the clinicians. They weren't having to sort of understand new ways of collecting data or understanding reasons for collecting data that was particularly unusual, or they couldn't see, what's the purpose of this in relation to this study. Also, I found that their focus on the human condition was really paramount. So I felt it was true science in practice. So yes, there was strong theory behind this. I mean, sleep studies go way, way back. So they really were arriving from a very strong base, but they were able to integrate that human condition and connectedness that I think made this sort of more, I guess, sustainable in the future. The reciprocal learning and education between researchers, clinicians and clients was really positive. So some of the researchers had direct contact with the clients. So I quite liked this side of it. That's not always possible in every research project, but they were able to do these one-on-one interviews. And when I had my first discussions with the research team, and we were talking about the watches that they had to wear, I think it was one of my colleagues was just about to say, oh, but what if one gets lost? And they jumped in ahead and said, oh, we've ordered extra because, some might get lost. We understand the people you work with. And I thought that just spoke volumes about how they had really got to learn and know our service and the clients that they were working with. So I felt that their purpose was very genuine and that the results would be very genuine. The research team also decided to use data and routine data collection tools already in use. So that significantly reduced the stress and really helped to control for data errors. One of the things, and this is kind of promoting my honours research, is I actually looked at the role of stress on data, like data entry and interpretation errors. So in my study, we made people very upset, and then we got them to peruse through a list of data to find the anomalies. And of course, we found that people in these really high stress environments were more likely to make more errors. And I think that's really important in working with an organisation like an AOD or mental health, is that the clinicians are incredibly stressed for the most part. They're really running on adrenaline. They're kind of sympathetic nervous system dominant most of the time at work. Really hard to struggle with that, basic memory function. So just, data in itself there's a high risk for it not to be consistent or for it to have errors. So I think as a researcher going in, is kind of talking about those maybe quieter times during the week where the clinician could enter information or data or sit down a bit more meaningfully, that they're not interrupted by these sort of other external factors as well. And also staying in touch with maybe management. So we do have incidences within our services that are really quite distressing. And if one sort of happened, then maybe we wait for a little bit till things calm down before we then keep moving forward with the research. So, okay, so moving on to policy then. So for those services and universities that might not have the current funding to do translational research, there's still, I think, a lot of value in being able to contribute to policy. I can give a really good example of that at the moment. I'm working on a working from schools policy. Because we're in the AOD organisation, a lot of schools are very keen to have us come out and speak about the terrible harms of drugs and to frighten the young children into never using. And of course, that is absolutely not our line, and that's not how we operate. But, you know, up until recently, we've generally done all right in just sort of explaining this to people, but there's now come a time we feel we need actually a solid policy to back this up. And in helping to put together this policy, like, we knew that that's what we wanted to do, but I felt that we needed to get some really solid evidence that said doing this to children causes harm, because logically speaking, it doesn't seem to make sense. If I tell kids not to do drugs, then that's a good thing. So to find something that was very counter to that logic was so important in getting this policy across. And that's where I was able to draw on a couple of really key pieces of literature, including the World Health Organization's standpoint on the issue. And that just gave for a really robust policy, and it was really hard to argue with it. So I think this is a really great space for even early career researchers and even organizations that are not sure about doing research within the organization, but are just dipping their toe in the water about, you know, creating maybe that connection with academia and the organization itself. I think it's mutually beneficial. So, and I'm going to even like flag Gab here because of her PhD thesis, looking very much at suicide and pain. And that is absolutely something that comes into our work. So there's such an opportunity there for her PhD and her real sort of expertise to come to help inform us to be able to keep our clients safe. So it's often a simple thing, but very effective as well. Also great grounds to talk about research gaps. They certainly come up in this space. You'll really start to notice them. And then finally, this is the discussion piece of our peer-reviewed publications. And we all love a good discussion piece because, let's be honest, that's where we go to first to see if this is something we're going to read more of. I've found these so invaluable just in my work, clinical work, and organizationally working with clients, is looking at the fact that, you know, every publication has its purpose. I did have a look. I had this number that was thrown around probably back when I started uni in 2000, that only 20% of journal articles ever get read. I don't know how consistent that is, but I looked it up. I've constantly heard that figure again and again. 90% of them never get cited. Generally speaking, only 10 people will ever read your publication from start to finish. They are likely to be yourself as the author and potentially your mum. So unfortunately, I think there's so much good information that gets lost out there, or people just can't translate it into that practical setting. So this was one that I read not that long ago, and I just delighted in that little bit that's highlighted, was the authors were kind enough right at the end to say, this is how this research translates into a practical outcome. And it was so helpful. And I put that into a particular document I was working on. And it was, you know, they'd never geared up to do this translational research. They just found the relevance and they let me know about it. So I think it's an area as well that, you know, you can make a difference, even if your research is quite complicated, or, you know, you don't see there's an easy stepping stone. Hence why I've got the little steppy stones there. The valley of death does not always need to be traversed for good outcomes. And finally, from the bench now to the bedside, so that'd be my side of things. And what can we do to sort of help bring on academic research and that kind of investigation and inquiry? So from my experience in working across all of those organisations, what I found is really great is you've got to get a culture of research in the organisation. You've got to get people on board with the idea of and value of collecting research, what it can do to the clients, what it does to the clinicians, what it does to the sustainability of a program, the longevity of the program. I think that's something Lives of Well is doing so well at, is getting this culture of research, and people are passionate about it. So much so, somebody overheard a gentleman at Mirakai once talking to his peer saying, oh, you should get involved in this research study they were running at the time. And he said, oh, I didn't know they sort of did research. And he said, yeah, Lives of Well, that's research. That's just what they do. And I thought that is the biggest compliment, that even our clients are seeing that as part of our culture. Really important getting everyone on board. We're rolling out a bit of research trial at the moment, a huge one. And I've actually found when the leaders are on board and team leaders are on board, it makes life so simple. Having really clear supporting policies. So that's, very much from our perspective. Things like adequate funding and time, because it is a big commitment. And do we have the time within our own schedules to be able to commit to this project? Having really clear boundaries of what's in and what's out. So again, that was maybe where Red Cross went a little bit wrong with that one. So their particular boundaries is, yes, they were up for this kind of working with, young people and this kind of humanistic approach, but it came at, the cost of, we might not want to do harm reduction. And then also being aware of sustainability of future outcomes and recommendations. So often these projects will produce recommendations, and to quote my mate Craig again, you don't want these to end up on a shelf somewhere where no one's looking at them. So you want to really have right at the beginning, yes, we'll continue on with this, we can embed this. Also find your champions. So there's always one through, I think we've got over 400 clinicians, 450 clinicians in Lives of Well. There are a lot that are so passionate about research that would jump on board with this, that would advocate for this. And that's something, to discover early on and sort of help them to achieve that culture of research. Start really small if it's never been done before. Invite research into simple projects in more of a consultative process. So we had a lovely example of that. We had Zoe from UQ came out and sort of worked with a team of ours from Western Queensland to help them with a particular project, a little research project they were conducting. And all she did was just to help structure the questions that they were going to ask as part of qualitative interviews. And it was simple, but it was so effective. And it was a lovely example of the two coming together for a better outcome. And also definitely involving clients at all levels and all levels of staff to identify these research opportunities. I think a really big one is always coming back to your clients and to your clinicians with the research outcomes. We had a particular incident a couple of years ago where a particular region looked like there had been a massive increase in cannabis use in their young people. And it was really worrying because that's not a good look for an organisation or for a program. And when we asked a little bit deeper and consulted with the clinicians and the clients, we found out that there was actually a lot of sorry business in the community at the same time we were collecting outcome measures. And this had nothing to do with the program. This was an external factor we couldn't control. But no way would we have known that had we not gone back and sort of asked the teams again to help in interpretation. And always that constant communication. I can't express it enough. Everyone wants to know what's in it for me. So find a way of telling them what's in it for you. You'll have a lot more success. And that comes to the end. Thank you very much for your attendance. And I really hope that this is something that's helpful moving forward and everyone can see value as organisations and academia working together. I think there's a lot of positives always.
Fantastic. Thank you so much, Holly. Really, really useful, really interesting to listen to. We've still got about 5-6 minutes if there's question time, if you're willing. So is anyone wanting to say something or any questions? Gab, I can see your hands up.
Yeah, I have a question. So Holly, it's fantastic because you do really have a great understanding of both research and sort of the organisation side, and it's really, really great to see. And you gave some really good examples in your presentation with Burnett and sort of Red Cross and how well, and the sleep study, how people work well with implementation when they're working with organisations. And just for, I guess, there's pure academics here, what would be your probably like a list of, say, I don't know, you can make it whatever, but definitely do not do when you're sort of doing implementation work with organisations?
I would say in that case, a little bit like the way my organisation has sort of got into this, they've picked, I guess, a champion for words, which is really my role. The fact that I'm called a research and outcomes coordinator, my role was totally created for having that relationship between the university and our organisation. And I was actually interviewed by someone from UQ when I went for my job at Lives of Well. So I think vice versa, in that kind of strict academic sense, there'll be people in there that enjoy the social networking opportunity, that they want to go out, they want to do site visits. And then there's those that just don't want to, they're really just happy to sort of push through the statistics, and both are equally as valued. I would definitely sort of look at identifying the strengths within a research team. Certainly Burnett, this is what they did. They deliberately picked Cassandra because she was young, she had a background in youth research, and she was chatty. So, and they pushed her out into the front line. Then we've got Paul Dietz, I think was one of them, and a couple of the other heavy academics that were supporting that. I never saw them or heard from them, but they did a good job. They're in the background sort of pushing stuff along. So I think, yeah, in going in, the best thing you can do is listen before talking, basically. 100% get to know the organisation. Often what you see is what's sort of not happening all the time. It's, yeah, very... I think things changing, particularly in a high stress organisation like ours. You could have dealt with a near suicide the day before, and then today you're bringing cupcakes for morning tea. So I think it's, yeah, really, really tricky. And being realistic, asking, you know, which measurables or which variables do you find easy to collect without much effort? I think then you get easier wins.
Thanks. Yeah, because I'm aware that, yeah, sometimes drug and alcohol services do kind of feel, their clients can feel like they're sort of, you know, just the research
guinea pigs,
and then people don't give or don't disseminate the research back, and there's nothing, that's just people going in and taking and then not giving anything back.
Yeah, I think with Logan House a little bit, because their suggestions were things like getting up and walking early in the morning to sort of help with the circadian rhythms. And so that was something that was immediately given back to clients to be able to say, because you were involved in this, this is the outcome. That was lucky because it's short term. You don't always get that kind of luck. I did question around whether clients would want to see results, and their feedback was not in too much detail, maybe just a little pager, you know, right at the very end. They were happy to have it emailed to them, but they didn't want to know too heavily what it was about.
Yeah.
Yeah.
Nice, thank you. Anyone else? Any other questions or feedback that people wanted to raise?
I'd just like to say to Holly, well done. And we couldn't even tell that you were nervous.
Cheers.
Yep, absolutely nailed it. Seconded you.
Nailed it.
And that's Craig, who I was talking about. Name dropping Craig, and his amazing work with clients and starting to really pull that into some of what we're doing.
Amazing. Okay, well, I think we've only got about a minute left. So if there's no other thoughts or feedback, was there anything that you wanted to finish up on, Holly, or shall we draw it to a close?
Just thank everyone for their passion in translational research. It's hard. We're in the valley of death together. We will get through it. It's worth it.
Fantastic. Thank you. Well, I'm seeing lots of thank yous popping up in the chat, lots of great jobs, lots of well done. So I think all of those are testimony to the value of your presentation and what everyone has taken from it today. So yeah, thank you for your willingness to present to us all.
Thanks very much, Ali.
Wonderful. Well, I think we shall draw it to a close then, and everyone can go back to the rest of their very busy days. Look forward to seeing you at the meeting next time round.